Imagine walking into, a locked ward of a state psychiatric hospital. You pass the usual sights, but then you notice this man sitting alone at a heavy, worn, wooden library table right in the middle of the day room.
Right, and this isn't just any patient.
No, exactly. This is a man with just a crackling intellect. Think Einstein-esque hair, a long history of massive academic success. He was, until very recently, a highly esteemed professor of anatomy.
Which really makes what he's doing at that table so striking.
Yeah, because his table is just entirely covered in papers. I mean, on every single page, he has compulsively drafted an anatomically precise drawing of a human retina.
And these aren't just erratic, manic sketches. They are the meticulous schematics of a master anatomist.
Spot on. But with one bizarre, impossible detail. Inside each of these beautifully rendered retinas, he has drawn these elaborate refracting machines. Tiny prisms, complex, intersecting lines of glass.
Because he's suffering from these vivid, relentless visual hallucinations.
Right. And he firmly believes that the source of his psychosis is literally, mechanically, located inside his own eyes. He is trying to draft the optical mechanics of the hallucinations that are tormenting him.
It's a tragic but fascinating image. And it brings us to the core anchor of our deep dive today, drawn straight from Chapter 12.11 of Kaplan and Sadok's comprehensive textbook of psychiatry.
Which is such a crucial chapter for you, the listener, whether you're a trainee or just a curious student.
Absolutely, because it frames psychiatry as the study of how the brain, the mind, and experience interact, and crucially, how that entire process can just go wrong.
Okay, let's unpack this. Let's look at this professor, because this is where standard clinical reasoning starts to break down. We look at him. He's got chronic hallucinations, delusional elaboration, a massive functional plunge. The immediate clinical label we reach for is schizophrenia.
Of course, that's the box he fits into.
But if we know the classic Kraepelinian model, this presentation rings entirely false, doesn't it?
Oh, it rings false on almost every front. First off, there's the cognitive preservation. Classic schizophrenia typically involves a pretty significant neurocognitive decline.
Right.
But our professor retains this exceptional intellectual capacity to draft these highly complex diagrams.
And his speech is fine, right?
Exactly. There's no prominent formal thought disorder, which historically was considered, the absolute hallmark of the illness.
Yeah.
And finally, the timeline. Psychotic disorders of this nature usually emerge in late adolescence or early adulthood, not after a lifetime of high-level professional achievement.
So the diagnosis of schizophrenia describes the end state, like what is happening to him, but it completely fails to explain why it's happening.
Which is a huge problem in our field.
And this brings us to a concept I really want to challenge you on. Fisher and Carpenter proposed this fever versus infection framework, right?
Yes, a really pivotal idea.
Suggesting that a psychotic experience is just the fever, and our DSM labels are basically just categorizing fevers.
But hold on, if I'm a clinician, I use the DSM-5 every single day.
Are you suggesting the diagnostic categories we rely on are fundamentally flawed?
Well, not flawed for their intended purpose, which is reliability, but they are deeply flawed when it comes to biological validity.
Okay, unpack that for me.
Let's look at it objectively. The DSM criteria give us high diagnostic reliability. You and I can look the exact same patient, tick the same boxes, and agree to call it schizoaffective disorder.
Right, we agree on the label.
Exactly. But as Dr. Steve Hyman pointed out, these categories are a poor mirror of nature. They just don't map neatly onto biology. If we look at genetic vulnerability or cognitive deficits or even just treatment responses, there is massive overlap across schizophrenia, bipolar disorder with psychosis, and schizoaffective disorder.
Because they don't breed true in families,
Yeah.
right? Like, you might have a patient with schizophrenia whose sibling has bipolar disorder.
Precisely. And we give antipsychotic medications to target the psychosis across all these categories rather than treating a unique biological mechanism within each one.
Yeah.
The cabinets in the archive of psychiatric classification, they classify human experiences. They do not classify biological diseases.
I mean, diagnosing psychosis purely by a clinical interview is basically like trying to diagnose a car's engine failure by only looking at the color of the smoke coming out of the exhaust.
That's a great way to put it.
The black smoke, the hallucination, it tells you there's a serious problem. But you cannot fix the engine until you pop the bonnet and actually look at the mechanics.
And popping the bonnet is exactly what the BSNIP consortium set out to do.
BSNIP.
Yeah.
That stands for the Bipolar Schizophrenia Network for Intermediate Phenotypes, right?
Yes.
Let's define that term for a second. Intermediate phenotypes, or endophenotypes. We're talking about biological or cognitive markers that sit sort of halfway between the raw genetic code and the outward clinical behavior.
Exactly. There are quantifiable features that are much closer to the actual functioning of the brain's circuits.
Okay.
So instead of starting with the top-down clinical diagnosis where we put people into DSM boxes and then look for differences, BSNIP worked bottom-up.
I love this. So what did they actually do?
They took large transdiagnostic groups of people across the entire psychosis spectrum. They threw out the assumption that the DSM labels were biologically meaningful, and they just started measuring the machinery.
Okay, let's play detective here. If the exhaust smoke is the clinical hallucination, what specific biological gears were the BSNIP researchers looking for under the bonnet?
Well, they deployed a massive battery of tests. They started with the brief assessment of cognition in schizophrenia, or the BACS.
Right.
This looks at memory, processing speed, reasoning, problem solving. But where it gets really granular is when they move to sensoromotor and inhibitory control using eye movement chambers.
Ah, the prosaccade and antisaccade tasks. This is fascinating neuroscience. So, in the prosaccade task, a target flashes on the periphery of a screen, and the subject just has to look at it as fast as possible.
Right. And that just measures the raw speed of visual orienting. It's essentially an automatic subcortical reflex driven by the superior colliculus.
It's easy.
Very easy. But then comes the anti-saccade task. A cue flashes on one side of the screen, but the rule is you must actively resist the automatic urge to look at it and instead force your eyes to look in the exact opposite direction.
Oh, wow. So you are measuring inhibitory control under perceptual conflict.
Exactly.
You're basically testing the brain's cognitive brakes.
Yeah.
It's like trying to stop yourself from hitting send on an ill-advised text to an ex at 2 in the morning. Your thumb wants to do it automatically, but your prefrontal cortex has to slam on the brakes and override that motor program.
That is a highly relatable and actually very neurologically accurate analogy. They also use the stop signal task, or SST, which tests exactly that. You are instructed to press a button when you see a cue, but occasionally, just a fraction of a second after the cue, a stop signal flashes.
So you have to rapidly abort the physical action you've literally already initiated.
Yes. It demands immense top-down executive control.
And BSNIP didn't just measure behavior, right?
Yeah.
They hooked these patients up to 64 sensor EEG caps to watch the neural dynamics in real time.
They did.
But let's unpack the technical terms here, because the literature throws around things like P50 gating, N100, and P300 waves. What are we actually looking at on the monitor?
We are looking at how the brain prepares for, registers, and recovers from stimuli. Let's start with P50 gating, which is measured via a paired stimuli task.
Okay.
You hear 2 clicks in rapid succession. A neurotypical brain strongly registers the first click, but suppresses the neural response to the second click because it recognizes it as redundant.
Like filtering out the hum of a refrigerator.
Exactly. It's sensory gating. If you lack that, you are just overwhelmed by irrelevant stimuli.
That sounds exhausting.
It is. Then we look at event-related potentials like the N100 and P300 during an oddball task. That's where a subject listens to standard tones and has to detect a rare target tone.
Okay, break those waves down for me. Why do we care about an N100 versus a P300?
Well, the N100 is a negative deflection in the EEG wave that happens exactly 100 milliseconds after the stimulus.
Fast.
Very fast. It represents the brain's initial pre-conscious sensory registration. It's the brain basically saying, I heard something.
And the P300?
The P300 is a positive spike at 300 milliseconds. That wave represents cognitive evaluation and working memory updating. That's the brain saying, that tone was the target I was looking for. This matters.
And they aren't just looking at the volume of these electrical signals, the voltage, but also the frequency bands. Things like delta, theta, and gamma. Why measure the frequency?
Because different frequencies act like different radio bands for neural communication. Gamma rhythms are very fast and are crucial for local high-speed processing and binding different sensory inputs together into one conscious experience. Okay. Theta rhythms, on the other hand, are slower. They coordinate long-range communication across the brain, like pulling memories from the hippocampus all the way to the prefrontal cortex.
Right, okay, so BSNIP has this incredibly high-resolution, multidimensional biological data. The cognitive brakes, the sensory gating, the N100 sensory registration, the gamma band binding.
An absolute mountain of data.
Yeah. And they take all this data and they map it back onto those heavy wooden diagnostic cabinets we talked about. Schizophrenia, bipolar with psychosis, schizoaffective. So, moment of truth. does the biological machinery neatly sort into our clinical boxes?
It fails spectacularly.
Rip.
When they mapped this wealth of biomarker data against the traditional DSM diagnoses, they found near total overlap.
Wow.
The differences were merely in degree, not in kind. The schizophrenia group tended to perform slightly worse on average, and the bipolar group slightly better, but the distributions just sat right on top of each other.
So a patient with bipolar psychosis could have the exact same neurophysiological impairment as a patient with schizophrenia.
Exactly. The biology does not respect the clinical label at all.
That is wild.
With one slight exception, though. The brief assessment of cognition in schizophrenia, the BACS, was the only intermediate phenotype that showed a clear, continuous gradient of severity across the groups.
Meaning what?
Meaning schizophrenia showed the most severe cognitive deficits, healthy subjects the least, with bipolar and schizoaffective in the middle. But as a whole, the clinical classification completely failed to predict the biological reality.
Which forces a radical pivot. Because the DSM labels failed, BSNIP just threw them out entirely.
It did.
They took all this biomarker data, completely ignoring what the patient's clinical chart said, and used a mathematical approach called k-means clustering.
Yes, essentially asking a computer algorithm based strictly on the biology, the EEG, the eye tracking, the cognitive tests, how do these human brains naturally group together?
And what did the algorithm find?
It revealed that nature doesn't carve these patients into DSM boxes. It clusters them into 3 distinct biological profiles, which the researchers called biotypes.
Let's break down these 3 biotypes, because this is the paradigm shift, right? This is the new mental model for understanding psychosis.
It really is. Let's start with biotype 1. This group is characterized by profound cognitive deficits and severely deficient neural activity.
Deficient in what way?
When you look at their EEG during those cognitive tasks, they have very low ongoing neural activity and drastically reduced N100 and P300 waves.
So they aren't even registering the sensory input properly at 100 milliseconds, and they certainly aren't evaluating its context at 300 milliseconds.
Correct. Their brains are fundamentally failing to detect stimulus salience. Physiologically, it is a deficit of neural activation.
It's like the brain's electrical engine is just starved of fuel. It just can't get the revs up.
That's a perfect way to conceptualize it. But then we look at biotype 2, and the mechanism is entirely the opposite.
Okay, what's happening there?
Biotype 2 is defined by severe neural disinhibition. Their brains show excessive ongoing EEG activity. And crucially, they fail spectacularly at the tasks requiring sensoromotor inhibitory control.
The anti-saccade and the stop signal task?
Exactly.
They can't pump the cognitive brakes. I mean, if I think about this mechanically, biotype 2 is like a broken noise-canceling headphone chip.
How so?
Well, instead of generating an inverse wave to filter out the background static of reality, the inhibitory circuits are broken, so it just amplifies every single frequency. The brain is flooded with raw, unfiltered data.
That is exactly what disinhibition looks like neurologically. The cortex is hyperexcitable. So biotype 1 is a starved, underactive network. Biotype 2 is a flooded, runaway network.
Which brings us to biotype 3, and I have to stop here because this one absolutely baffles me. How do we explain biotype 3?
Biotype 3 is the great humbling mystery of this research.
Really?
Yeah. Physiologically, across all these dense biomarker panels, the EEG, the eye tracking, the sensory gating, their data looks almost indistinguishable from healthy neurotypical subjects.
You're kidding.
No. They have the most normal biology of the 3 groups, and correspondingly, they retain the best social functioning.
But they are still experiencing clinical psychosis. I mean, they are hallucinating. They have delusions. How is that possible if their biological endophenotypes are basically normal?
It forces us to admit the limits of our current tools. It could mean that biotype 3 psychosis originates in a completely different neurobiological pathway that EEG and eye tracking simply cannot measure.
Like what?
Perhaps highly localized network disconnectivity or neurochemical imbalances that just don't disrupt these specific global circuits.
Oh.
Or it suggests that for this subgroup, the psychosis might be driven much more by psychosocial stressors and environmental factors than by massive structural neural deficits.
It's a humbling reminder that psychiatry is endlessly complex.
Absolutely.
So we have these 3 distinct biological mechanisms. But as a clinician sitting across from a patient, how does this actually translate back to the bedside? Do these biotypes actually look different in the room?
This is where the ultimate irony of the DSM is really exposed.
Okay, what's fascinating here is
The positive symptoms. The florid hallucinations and the complex delusions, which are the very things that drive traditional psychiatric diagnosis, they did not differentiate the biotypes.
Wait, really?
Truly, you are just as likely to have severe hallucinations whether you are the starved brain of biotype 1, the runaway brain of biotype 2, or the mysterious biotype 3.
So the most sensational, terrifying parts of the illness are literally just the generic fever.
Yes.
The hallucinations tell you almost nothing about which biological engine is failing.
Exactly. But the clinical symptoms that do align with the biology are the ones we historically paid a lot less attention to.
Like what?
For biotype 1, the deficient starved neural activity, their clinical presentation aligns with a cognitive deficit psychosis dimension. They present with severely blunted affect, disorganized conceptual thinking, and massive occupational deficits.
Well, that tracks perfectly. If the brain lacks electrical salience, the outward presentation is going to be blunted, flat, and disorganized.
Well,
What about the runaway engine of biotype 2?
biotype 2 corresponds to a neuroaffective dysregulation dimension. Because their brains are hyperexcitable and lack inhibitory control, clinically they present with extreme anxiety, odd mannerisms, stereotype thinking, and uncooperativeness.
So the outward behavioral dysregulation perfectly mirrors the inward neural disinhibition.
Exactly.
This raises an important question then. Let's bring this all the way back to our anatomy professor, sitting in the locked ward, drawing those prisms inside retinas.
Right.
Under the DSM, he was condemned to his schizophrenia diagnosis based on his hallucinations and his functional decline, right? Lumping him into a massive heterogeneous box. But if we look at him through the precision lens of biotypes, what changes?
Well, everything changes. We see a man with preserved, exceptional cognitive capacity. He can meticulously draft these anatomically precise drawings.
Which takes incredible executive function.
Exactly. And that alone tells us he is almost certainly not biotype 1. He doesn't have the profound cognitive deficit or the conceptual disorganization that defines that starved neural group.
Yet the entrenched clinical approach just grouped him with patients who have entirely different underlying brain pathologies.
It did.
By treating the positive symptoms, the visual hallucinations, as the disease itself, we completely missed his specific underlying biology. And if we don't know the mechanism, we cannot possibly tailor a treatment to fix his specific mechanical failure.
If we connect this to the bigger picture, this represents the absolute frontier of precision medicine and psychiatry.
It's long overdue.
Think about how oncology operates today. We don't just diagnose lung cancer based on a cough, right? We biopsy the tumor, we sequence its genome,
Right.
and we target the specific molecular mutation.
Right. And cardiology stratifies patients by inflammatory biomarkers and enzyme levels.
But psychiatry has lagged behind, relying entirely on outward observation. The BSNAP biotype approach is the first major structural step towards stratifying psychiatric patients based on underlying pathophysiology.
So what does this all mean for us? It means we have to move from top-down classification, grouping patients by their subjective experiences, to bottom-up classification, grouping them by their neurobiology.
Exactly.
Giving a standard antipsychotic to suppress hallucinations is necessary palliative care, just like giving paracetamol for a fever. But if we ever want to cure the disease, we have to find out if the patient is suffering from the neural starvation of biotype 1, the neural disinhibition of biotype 2, or whatever mysterious pathway is happening in biotype 3.
It fundamentally changes how we will research new pharmacological agents and eventually how we will conceptualize our patients in the clinic.
It really does. And before we move to our clinical reasoning check, I want to leave you, the listener, with a final philosophical thought to just mull over.
Oh, I like these.
If chronic hallucinations and complex delusions are nothing more than the brain's generic fever response to entirely different underlying biological failures, what does that tell us about the fragile way the human mind continuously constructs our shared reality?
That's a deep one.
I mean, if both a starved neural network and an overactive, disinhibited network default to generating elaborate hallucinatory worlds, our daily grip on reality might be much more tenuous and much more actively constructed by these background circuits than we ever realized.
A sobering thought. The line between reality and psychosis is governed by a very fragile mechanical balance.
All right, let's put this new mental model to the test with some clinical reasoning questions. I'll throw a scenario at you, listener, and we'll break down the rationale. For a deeper dive into the data, make sure you're reading alongside Chapter 12.11 in Kaplan and Sadok's comprehensive textbook of psychiatry.
Ready when you are.
All right, question 1. According to the BSNIP Consortium's findings, Which traditional clinical features were surprisingly the least helpful in differentiating the neurobiological biotypes of psychosis? Give yourself a second to think.
So the answer here is the positive symptoms, specifically hallucinations and delusions. Despite being the primary drivers of traditional DSM diagnoses, they acted entirely like a generic fever response, presenting basically equally across all the biologically distinct biotypes.
Spot on. Okay, question 2. Let's look at mechanism. Imagine a patient in the eye movement chambers. We need a specific task to measure their inhibitory control under perceptual conflict to reveal the prominent deficits we see in biotype 2. What task are we using?
You'd use the anti-saccade task. This requires the subject to actively resist the automatic urge to look at a peripheral visual target and instead force their gaze in the opposite direction. It perfectly isolates their sensory-motor cognitive brakes.
Excellent. Now, question 3. Think back to that massive panel of intermediate phenotypes. When mapping all that dense biomarker data to the standard DSM-5 categories of schizophrenia, schizoaffective, and bipolar disorder, which single biological measure was best able to demonstrate a continuous spectrum of severity across all those clinical groups?
That would be the Brief Assessment of Cognition in Schizophrenia, or the BACS. While the EEG and eye tracking measures showed massive overlap across diagnostic boundaries, cognitive impairment alone showed a clear severity gradient, with schizophrenia patients exhibiting the most severe deficits.
Fantastic. All right, question 4. Let's do a clinical vignette. A patient presents on the ward with profound neurocognitive deficits, severely blunted affect, and conceptual disorganization. He managed to get an EEG, and the testing reveals remarkably low N100 and P300 event-related potentials. Which BSNIP biotype does this biology and clinical presentation describe?
That describes biotype 1. The remarkably low N100 and P300 waves indicate deficient neural activation, basically a brain struggling to even register stimulus salience. And clinically, this maps directly to the cognitive deficit psychosis dimension.
Perfect. Finally, question 5. Let's lock in the core conceptual framework. The fever versus infection analogy in modern psychiatric nosology suggests that our current DSM-5 diagnoses primarily categorize what aspect of mental illness?
They categorize clinical phenomenology or the experiential symptoms. The analogy highlights that our current diagnostic boxes merely group together the superficial experience of the illness, the fever, rather than identifying the underlying biological disease entities, which is the infection.
And until we start popping the bonnet to look at the engine, we'll always just be chasing the exhaust smoke. Thanks for joining us on this deep dive. Keep questioning the clinical labels, keep reading the underlying mechanisms, and we'll see you next time.